Good evening to everyone. We'll start with second trimester screening and the Google form that I shared in the group. It was just for checking our knowledge about first trimester screening. I'll tell you the answers first because still we had some confusions regarding the answers, and 75% of the people answered correctly, but grossly 25 to 30% were wrong. So the answer to the first question, that is, what is the ideal time for first trimester screening? Majority answered 11 to 14 weeks, which is correct answer. So actually it is 11 weeks to 13 weeks, 6 days, and not 11 to 13 weeks. By this we mean कि 13 weeks हो जाने पे screening नहीं कर सकते, ऐसा नहीं है. 13 weeks, 6 days यानी कि 14 weeks तक हम कर सकते हैं. Second is, what do we screen for in first trimester screening? Are we screening in first trimester for neural tube defect, for aneuploidy, for molar pregnancy, or for placental abnormalities? It is actually aneuploidy screening. By ultrasound, we see aneuploidy markers, but we can detect anencephaly, that is a neural tube defect, during first trimester ultrasound also. But the answer is aneuploidy. Third question was, what are the options for first trimester screening? And the options were NIPS, ultrasound, dual markers, all of the above. What we have to understand is what is the best standalone test. So NIPS gives a good sensitivity and specificity. Ultrasound as a standalone test, no. And dual markers as a standalone test, no. That is why we prefer combined first trimester screening. Next question was, what do you understand by combined screening? It is ultrasound plus biochemical markers, that is dual markers, PAP-A and beta HCG, plus maternal age. And rest of the options are incorrect. Next question was, what is contingent screening protocol? So majority have answered correctly. That is first trimester plus second trimester screening, and we will discuss that today. And then the question was, when should we start NIPS-based screening? Correct answer is 13 weeks, but NIPS for screening can be sent or done from 9 to 10 weeks, as early as 9 to 10 weeks also. The last question was, NIPS-based screening can be taken as diagnostic test also. So the answer is no, however sensitive or specific it may be. We cannot base our decisions based on NIPS only. So welcome to second lecture, that is second trimester screening. I hope first trimester screening is clear now. Yeah. So in second trimester screening, obviously 13 weeks, 6 days, that is 14 weeks have elapsed by, and we want to screen for aneuploidies in second trimester now. So again, a brief discussion about the aneuploidies, because in previous lecture, I wanted to discuss it, but time was less. So first is Down syndrome, and that is trisomy 21. It is responsible for around 50% of the detected aneuploidies when we screen these pregnancies. There are two types of chromosomal aberrations that we see in trisomy 21. First is meiotic non-disjunction of chromosome 21, and second is translocation. So non-disjunction wala is maternal age dependent. So as the maternal age advances, this chance gets more elevated. Translocation is maternal age independent. If there are translocations and problems, they can happen at any maternal age. So what are the stigmata of Down syndrome? We see Mongolian facies, that we used to call it previously, not now. So flat back of head, abnormal ears, many loops on fingertips, palmar crease, single, special skin ridge patterns, unilateral or bilateral absence of one rib, intestinal blockade may be there, congenital umbilical hernia, abnormal pelvis. There is floppy muscle tone, and the eyes are slanting. Epicanthic eye fold is slanted. There is short nose, short and broad hands, small and arched palate, big wrinkled tongue, and dental abnormalities. With this, congenital heart abnormalities are quite commonly associated. Congenital megacolon, and big toes widely spaced, that is sandal gap, is also very commonly seen. So Edwards syndrome is trisomy 18. We have microcephaly in this syndrome. Back of the head is prominent, as you can see. Ears are malformed and low set. Mouth and jaw are small, micronathia, and they may be associated with cleft lip or cleft palate also. Hands are clenched into fist. You see here, they are clenched into fist, and index finger overlaps other finger like this. So club feet or rocker bottom feet is quite pathognomonic of Edwards syndrome, and toes may be webbed or fused sometimes. So we see a raised NT, most common sonographic finding in its early stages, that is in first trimester. So what are the other features of Edwards syndrome? First is FGR, if you see them late. So early onset FGR, especially when we are doing an AMBLY scan or a level 2 scan, what we commonly know as, and if we see growth restriction there, then we should be worried about some aneuploidies, and commonly it is Edwards. Then other thing which is important for if you're preparing for NEET PG, strawberry shaped skull. It is also a hallmark feature of Edwards syndrome. Clenched fist, congenital heart defects, omphalocele, cleft lip, micronathia, rocker bottom feet, and renal agenesis are associated quite commonly. I mean, this makes the whole Edwards syndrome. So what is Patau's? It is trisomy 13, and we have a small head, absent eyebrows, cleft lip palate, dysplastic or malformed ears, clenched hands again, and polydactyly and extra fingers, undescended or abnormal testes. So in this feature also, you may see club fit of varying intensity. It is quite commonly associated with single umbilical artery and omphalocele. So brain abnormalities like ventricular dilatation, microcephaly, the head abnormality is also seen, and cardiac defects are invariably associated with all three aneuploidies that we commonly detect for. So what is the basic of second trimester screening? So first is we start from 15 weeks to 20 to 21 weeks or 22 weeks. To 21 weeks according to American College, 22 according to Royal College. Plus we do quadruple markers in this trimester. So along with quadruple markers, a detailed anomaly scan has to be done, which is done from 16 weeks up till 23 weeks. Now, you may, there is no need to get confused, because some people say, or some literature papers say that level 2 ultrasound or anomaly ultrasound can be done up till 21 weeks. Some say 22, some say 23, but 23 weeks tak bhi you can do. So if first trimester screening is not done, then is done, sorry. So if you are seeing any patient in which you have already done 12 markers and NT at that time, and the pregnancy is low risk, then you don't do quadruple markers in such a case. From the point of view of trisomy 21, if there is another concern, that you may, design the quadruple marker testing according to the patient, but not for trisomy 21. Trisomy 21 mein agar first trimester mein low risk hai, you don't do a quadruple marker test and you directly offer them a detailed anomaly scan. So what is actually quadruple marker? It consists of alpha-fetoprotein, HCG level, estriol, and inhibin. Alpha-fetoprotein is a protein released from fetal membranes. And in case the fetal membranes are exposed, like there are ventricular wall defects or so, then the range by which it is emitted is quite high. So 2.5 multiple of median is the upper limit, and it is in neural tube defects, it is seen in more than these limits. HCG is increased in Downs and decreased in Edwards and Patau. Estriol, which is a common estrogen found during pregnancy, is lower in two important conditions, and the value that we take over here is less than 0.25 multiples of median. So what are these two important conditions? First is Smith-Lemeli-Opitz syndrome. It is also associated with CNS defects, heart defects, kidney abnormalities. And second is X-linked ichthyosis, and associated with fetal growth restriction and so many other conditions also. So estriol should normally be okay level in pregnancy, because यही एक variety of estrogen है which is present during pregnancy. अगर ये कम है तो वी शुड बी लुकिंग फॉर अदर कॉन्जेनाइटल एबनॉर्मेलिटीज एंड दीज टू सिंड्रोम्स, दैट इज SLO syndrome and X-linked ichthyosis. So inhibin B is increased in Down syndrome. So as I said, when to start? It starts from, the screening starts from 15 weeks, and by 20 to 21 weeks, quadruple marking should be done. So if a first trimester screening, dual markers and NT has already been done, then you don't offer a quadruple marker, but offer a detailed fetal anatomic surveillance, which we commonly known as level 2 scan. So what are the types of screening in second trimester that you can offer to your patient? So first is an integrated screen. Integrated screen का मतलब हुआ फर्स्ट ट्राइमेस्टर और सेकेंड ट्राइमेस्टर के स्क्रीन को इंटीग्रेट कर लिया. सो रिजल्ट्स आफ्टर फर्स्ट प्लस सेकेंड ट्राइमेस्टर स्क्रीनिंग ही हम आउट करते हैं. फॉर एग्जाम्पल, इफ अ पेशेंट इज कमिंग टू यू, यू हैव डन इन फर्स्ट ट्राइमेस्टर से 12 वीक्स, उसका डुअल मार्कर हो गया और उसका एंटी स्कैन हो गया. सो रिजल्ट्स आर नॉट told to her unless there is something gross. Then she is again called for second trimester screening. Then the composite likelihood ratio and risk is calculated, and it is told to patient. It has quite good detection rates. Second type of screening is sequential screening. और sequential में दो तरह की screening होती है. First is stepwise sequential. Stepwise में क्या होना है? In first you have done a first trimester screening. In high risk, obviously we will send them for diagnostic testing, but in low risk, उनको आप second trimester screening भी offer करेंगे. And now it is on, patient, that is a patient's choice if she wants to go for second trimester screening or not. But इसमें integrated screen और sequential stepwise screen में difference क्या है? Integrated screen में result हम first trimester screening का नहीं बता रहे. रिजल्ट हम जब भी बताएंगे जब हमारे पास सेकेंड ट्राइमेस्टर स्क्रीनिंग का रिजल्ट भी पता हो. बट सीक्वेंशियल स्टेप वाइज में हम फर्स्ट ट्राइमेस्टर स्क्रीन का रिजल्ट पेशेंट को बता रहे हैं कि यू आर लो रिस्क एंड नाउ वी आर ऑफरिंग यू सेकेंड ट्राइमेस्टर स्क्रीनिंग ऑल्सो. कंटिजेंट स्क्रीनिंग में क्या है कि आपने फर्स्ट ट्राइमेस्टर स्क्रीन किया और रिजल्ट को लो, इंटरमीडिएट और हाई रिस्क में डिवाइड कर दिया. सो व्हाट इज लो? जब रिस्क of having aneuploidy is less than 1:1500. तो अगर लो रिस्क में आता है तो उसको रूटीन यानी कि लेवल 2 स्कैन के लिए बुला लेंगे. अगर इंटरमीडिएट रिस्क कैटेगरी में आता है फ्रॉम 1:1500 to 1:30, वी कॉल देम फॉर सेकेंड ट्राइमेस्टर स्क्रीनिंग. क्वाड्रुपल मार्कर भी करते हैं. बट इफ शी इज हैविंग अ रिजल्ट दैट इज हाई, दैट इज मोर देन 1:30, then we offer them diagnostic testing. तो इसमें आपने कंटिजेंसी प्लान कर ली है कि लो रिस्क में हमें रूटीन में फॉलो करना है जो भी हम करते हैं, इंटरमीडिएट में हम सेकेंड ट्राइमेस्टर स्क्रीनिंग के लिए भी बुलाएंगे और हाई रिस्क में हम डायरेक्टली डायग्नोस्टिक टेस्टिंग ऑफर करते हैं. सो आई होप दिस इज क्लियर बिकॉज दिस इज क्वाइट कंफ्यूजिंग. These words are confusing and the concept is quite hazy, but I'm sure it will be clear now. Then what about ultrasound? In ultrasound, detailed anomaly scan from 16 to 21 or 23 weeks, we see two things: major structural defects and soft markers. Structural defects क्या हो गए? major, सर ही गायब है, स्पाइना बाइफिडा है, लिम्स नहीं है या शॉर्ट है, कुछ मतलब इस तरह का है. बट सॉफ्ट मार्कर्स क्या हुए? ये अदरवाइज नॉर्मल वेरिएंट्स हैं. इन आइसोलेशन इन सॉफ्ट मार्कर्स में प्रोग्नोसिस उस फीटस की इफेक्ट नहीं होती है. अगर कोई एन्यूप्लॉइडी आपने स्क्रीन की है और लो रिस्क पेशेंट है, उसमें स्क्रीनिंग में एन्यूप्लॉइडी का रिस्क ज्यादा नहीं है और सॉफ्ट मार्कर है, तो वो एक नॉर्मल वेरिएंट है एंड फीटस के मतलब फर्दर प्रोग्नोसिस पे उसका बहुत खास फर्क नहीं पड़े. देन वी सी व्हाट आर दीज स्ट्रक्चरल डिफेक्ट्स. ग्रॉसली न्यूरल ट्यूब डिफेक्ट्स as we know of. Otherwise, aneuploidy, these selected major fetal anomalies, abnormalities that we can see on ultrasound, like cystic hygroma, ventriculomegaly, holoprosencephaly, Dandy-Walker malformation, cleft lip palate cardiac malformation, diaphragmatic hernia, atresia of duodenum, and esophagus, gastroschisis, omphalocele, and clubfoot. If you see, birth prevalence is 1:5,000 over here, but aneuploidy risk in percentage is 50 to 70%. And the common aneuploidies associated with cystic hygroma are 45X, monosomy, 21 trisomy, 18 and 13, and triploidy also. So it means if we have major structural defect identified, there are quite high chances of having common aneuploidies in these fetus. Then when we come to soft markers, we can see soft markers in first trimester. Can you stop talking, please? So soft markers. So first is first trimester marker. And first trimester marker, which is very progress, is nuchal translucency and nasal bone. And please understand that the nuchal translucency is different from nuchal fold thickness. So NT is again taken for gestational age. There are gestational age specification. I told in yesterday's lecture that nuchal translucency at 11 weeks and nuchal translucency at 13 weeks will be different. So the nomogram that we have for gestational age specific measurements should be used, and there should not be a single gate or abnormal. But the value that we consider abnormal is more than 3 millimeter. And if at all this happens, they should be referred for further evaluation. In second trimester, nuchal fold thickness of more than 6 millimeter from 15 to 20 weeks is abnormal. Echogenic intracardiac focus, having echogenic bowel, pelvis dilatation, femur and humerus length shortening, absence or hypoplasia of nasal bone, or presence of choroid plexus cyst. So we will understand this. What do we mean by this? So first let's come to nuchal fold thickening. See, इसमें likelihood ratio of association with trisomy 21 with increased nuchal fold thickening is 11 to 17. But prevalence in unaffected fetus is 0.5%. Now, if we see echogenic intracardiac focus in any pregnancy, the likelihood ratio of this to be associated with trisomy 21 is 1.4 to 2.8. But it is normally present in 3.8 to 3.9% of the unaffected fetus. So what do we understand by this? We understand that if we have any one marker out of these, like short femur, short humerus, echogenic bowel, then the likelihood ratio for trisomy 21 is 1.9 to 2. Otherwise, it is 10 to 11.3. It is normally present. Like one marker ka significance, you can yourself see कि 10 to 13, 11% of the fetus will have these if they are, even if they are not affected with aneuploidies. Now, what if two markers are present, then likelihood ratio obviously increases, and it is very low. Like two soft markers की presence in unaffected fetus is quite low. Then if the markers are 3 or more, तो उसका likelihood ratio तो बहुत बढ़ गया है. And you see here कि 3 soft markers का presence normal fetus में बहुत कम होता है. So if 3 soft markers are present, एक second. So if 3 soft markers are present, then the likelihood ratio for aneuploidic association, especially we are talking in context of trisomy 21, it is quite high. और 3 soft marker normal fetus में सिर्फ 0.1 की prevalence में मिलेंगे. So further going for soft markers, because this is a common area of confusion when we see them reported by a sonologist. Echogenic intracardiac focus है, आपने उसका NIPS कराया हुआ है, या पहले आपने उसको फर्स्ट ट्राइमेस्टर स्क्रीन कराया है. So what do you have to do? You have to do nothing. And follow-up imaging except like 24 weeks या कुछ और करने की भी जरूरत नहीं है. What if you see an echogenic bowel and if she is screen negative, तो उसमें आपको कुछ नहीं करना है. But yes, अगर स्क्रीन पहले से नहीं हुआ हुआ है, then you counsel for either NIPS, quadruple scan, so that you can give them a calculation about the risk of aneuploidy and evaluate them क्योंकि echogenic bowel is associated with congenital viral infection also, intraamniotic bleeding also. So you keep them under your follow-up and call them a third trimester also for reassessment and evaluation of growth. Now, choroid plexus is very commonly reported. अगर स्क्रीन नेगेटिव है पहले कराया हुआ तो कुछ नहीं करना है, और अगर स्क्रीनिंग नहीं है तो यू ऑफर देम एन आईपीएस और quadruple scan and post them up for routine care if they turn out to be negative in second trimester screening also. Now, ये absent और hypoplastic nasal bone. अगर इसमें एनआईपीएस नेगेटिव है पहले आपने कराया तो कुछ नहीं करना है, रूटीन केयर में उसको डाल देना है. अगर सीरम स्क्रीन हुई है 12 मार्कर्स वगैरह तो काउंसलिंग फॉर नो फर्दर टेस्टिंग वर्सेस नॉन इन्वेजिव वर्सेस इन्वेजिव टेस्टिंग फॉर एनएफआईडी शुड बी डन. हियर यू शुड टेल देम कि यू कैन गो फॉर स्क्रीनिंग टेस्ट और अदरवाइज यू कैन ऑप्ट आउट ऑल्सो. अगर कोई पहले स्क्रीनिंग नहीं हुई है तब तो आपको उसको नॉन इन्वेजिव और इन्वेजिव टेस्टिंग फॉर एन्यूप्लॉइडी के लिए काउंसिल करना चाहिए. लाइक यू टेल देम द ऑप्शन कि इट इज योर कॉल. Then the single umbilical artery, if for first trimester screening has been done or earlier serum screening has been done and it is negative तो कुछ नहीं करना है, और previous screening नहीं हुई है तो offer कर दो, but consider them for weekly antenatal surveillance because third trimester examination and evaluation especially they are associated with fetal growth restriction. एंड अगर उसके साथ कोई अदर मेजर स्ट्रक्चरल एनोमलीज हैं लाइक कार्डियक डिफेक्ट्स एंड ऑल, then you don't screen them and if they are screen naive, they did not go for a screening earlier, then you don't counsel them for a screening. उसमें तो अगर स्ट्रक्चरल डिफेक्ट दिख रहा है तो हम स्क्रीनिंग ऑफर नहीं करते. So this we have discussed. So one is a case scenario, first trimester screening is not done. Then what do? You offer up such a patient a quadruple marker and detailed anomaly scan. So this is quite a common scenario. आपने maybe first trimester में उसको option दिया you can go for dual markers and NT scan. She did not get it done. She comes to you. Now you give her option of quadruple scanning and ultrasound. You can offer her NIPS and ultrasound also. So neither of them substitute for each other. कि अगर आपने quadruple scan कर दिया तो you can skip a detailed anomaly scan. या आपने NIPS कर दिया then she can skip a detailed anomaly scan. That is her choice. अगर आपने first trimester screen किया था और अभी वो low risk है और अब आपको level 2 ultrasound में एक soft marker मिल गया तो what will you do? Now I'm waiting for answer. Why NIPS? I just discussed that if we have one soft marker in ultrasound and first trimester screen was negative, you don't do these things. एक soft marker में prevalence aneuploidy का कम होता है. But if first trimester screening is not done and one soft marker in ultrasound is present, what do you do? So now the question has come, quadruple test. Any other thing that you can offer? Here you can offer her an IPS. So yes, so answer are correct, quadruple or NIPS. You have already done ultrasound and first trimester screening नहीं हुई है, तो उसकी aneuploidy screening के लिए you can either offer her NIPS or quadruple test. It's patient's call what she wants to go for. So any questions? I'll be stopping this.